Welcome to a special CPC Plus Tactics to Go podcast. This is part 2 of a 3-part series on behavioral health integration. You are listening to the episode, Care Management for Patients with Mental Health Conditions. I'm Jennifer Boaz with the CPC Plus team, and in this episode, we'll discuss the key elements that make up the behavioral health care management model. We continue to listen in on a conversation between two subject matter experts, Wendy Bradley and Dr. John Williams. Let's start by hearing from Dr. Williams, who provides an overview of this model that explains what integrated behavioral health care management means for him as a primary care provider.
The big picture is that care management for behavioral health conditions is team-based care. So as opposed to the way I used to do it, which is me and a patient, I now have a team to support the care of that patient. So the team typically consists of a primary care clinician, a care manager who has some specialized training in behavioral health care. They may not be a licensed clinical social worker or a psychologist. They may be someone who's a care manager for chronic medical conditions, but now has gotten some extra training to do this also for mental illness. It, of course, includes the patient. And then in its most robust form, you have a mental health professional, a prescribing mental health professional. So for example, a psychiatrist or a nurse practitioner, and their role is to provide consultation and supervision of the care manager. I want to talk for a moment about what it does for me as the primary care clinician. It gives me more confidence and experience in my ability to manage behavioral health conditions because I have a support structure there to help me. And that's absolutely true. It also makes me more efficient. So rather than having to do the PHQ-9 myself, the care manager has done it, reported the score back to me. It's a support structure that's designed not to take my time, but actually for me to use my time more effectively and more efficiently. And then that translates into more patients coming back and doing better. And so that's self-reinforcing. It makes me feel more expert. My patients are more likely to get better. And it actually takes less of my time. So it's just a win-win all the way around.
This overview of the model provides a team-based approach that includes both the behavioral health care manager and a prescribing mental health professional. Dr. Williams emphasized how these team members provide support and create efficiencies in how he cares for his patients. We want to focus now on roles of the behavioral health care manager and how they are integrated into the daily workflows.
Maybe we should take a few minutes and talk a little bit about the roles of the people on that team. And I can start by talking about what I perceive my role to be as the primary care clinician. We've already established that we have screening in our practice. So someone is screened positive, let's say on the PHQ-2. The PHQ-9 has then been done, and now I'm in the room with the patient. So part of my job is to explore the results of that validated instrument more with the patient and determine if there is a mental health diagnosis. And so I'll make a diagnosis, and then I will talk with the patient about treatment options. So a big part of my role is to do shared decision making with the patient, explain to them what the options are, understand their values and preferences, and come together with a treatment plan. The next step for me is to introduce them to the care manager and bring that support team in. When that care manager is co-located in my practice, like I have in my practice, I can text them and tell them I have someone to see you, and they can tell me, sure, knock on the door or call them later in the day or tomorrow.
Dr. Williams and Wendy are going to talk about a key element they call the warm introduction. Listen closely to their definition and its impact.
So I'd like to do what I'm going to call a warm introduction, not a warm handoff, because I'm not handing off their care. I'm bringing in another team member for team-based care. And so I'm going to introduce them to the care manager, and they're going to begin to do their role and their function. So maybe you can pick up and talk to us a little bit about the care manager role.
Oh, absolutely. But before I do, I really want to touch on what you said about the warm introduction. This is absolutely crucial when I'm being introduced as part of the team. This is actually a transfer of trust. This allows me to be introduced as part of the team and already establish rapport with that patient, which allows me to just jump in and get right to work, doing my screener, doing an assessment, and then also a brief intervention based on what's going on with that patient. So that warm introduction is incredibly important in just creating this seamless approach to the work. The other part that is very important about my role as a behavioral health care manager when I'm working with patients is that tracking and registry function. So once I've screened a patient, assessed a patient, done a brief intervention, and developed a plan, they go into a registry that I'm able to track how that patient's doing. But that tracking registry allows me to ensure that that patient does not fall between the cracks. So as a care manager, follow-up may be 3 to 8 months, really depending on the severity of that patient and how they're responding to treatment. It could also include my referring them out to a psychiatrist or psychiatric med provider, or even for traditional therapy, but I'm still tracking that patient and monitoring their care.
That's great. And I'm glad you brought up the issue of trust because I think it's important on a couple of levels. One is I know that my care manager does a structured assessment. And so if I slip up and I forget to ask about substance abuse, or if I slip up and I forget to screen for bipolar disorder, I know my care manager is going to do it. And so if those flag positive, that's communicated back to me, and it may lead to a very quick change in the management plan.
Yes.
So I have to trust that my care manager is going to do that structured evaluation, and that trust is built over time.
Now that Dr. Williams and Wendy have described how the primary care provider and the care manager work together, let's hear how this is happening in a CPC Plus practice.
We had a patient come to a primary care for an appointment as a follow-up from an emergency room visit. She went in with dizziness, was diagnosed with vertigo, came to her primary care office as her follow-up appointment, and while she was there, her score on her PHQ-9 was high. And so when speaking with her primary care provider, this is high enough and your depression symptoms are severe enough that we would start an antidepressant today. And so the patient really was adamant about not starting medication. However, she was open to starting therapy and counseling, doing some grief counseling with family members and also some individual mental health counseling. So from there, the depression care manager was brought in just so the patient was able to meet one of the behavioral health staff members. And the depression care manager, which is me, I call and check in a week later because that was going to be before that first new patient appointment with the therapist and before the follow-up appointment with primary care. One of the reasons that we implement the phone call touches is reinforcement of behavioral health treatment that they may have already started. So if they are seeing a therapist and they're doing certain models of therapy, have these coping skills been working for you? And it's an assessment piece as well because, you know, if they're saying it's really not and I'm feeling worse, or even if it's a follow-up call after medication implementation, you know, I'm not feeling better, I'm having some side effects, you know, the care plan is not set in stone, and so it's changed as it needs to be in appointments. They're brought in earlier, or they're reassessed, or they're reevaluated, or we know, okay, now we do need a psychiatry appointment, so let's get that scheduled as well.
That was Jessica Jennings, a psychiatric RN with Saratoga Community Health Center, who provided a great example of their team-based approach to behavioral health care management. Jessica also touched on some of the skills she uses to engage patients. Let's expand on that and spend some time on the skills and training that support this role.
All right, John, we definitely need to talk about training. That is the number one question that I get from practices, particularly that are in rural areas or not associated with a large system. They are often having an RN or an LPN or maybe even an MA do the role of a behavioral health care manager. They're doing some of that screening and follow-up. We had an RN that told her story. Their administrator actually sent them all to a mental health first aid training. She said that it made all the difference. And the very next day in clinic, she screened a patient for depression, and that patient had a positive score for suicide. She went ahead and used the Columbia screener, she said, and felt pretty confident that she knew what to do. She said that she kind of reflected on that and found that, there were a number of times that there were probably patients that had come into the clinic feeling that way. And it kind of made her a little sad that that those patients left without that extra support. But she said going forward, her and her team were prepared and knew exactly what to do and felt very empowered to be able to ask those questions and support those patients.
That's a great example of, a little bit of training going a long ways and being able to help patients more directly.
Dr. Williams and Wendy now begin to talk about how it's possible to adapt skills from managing medical conditions to managing behavioral health conditions.
It's a luxury if you have a large practice and you're able to hire, say, a licensed clinical social worker into this role. They come often with the training that's necessary. Yes. But not all practices are that way. And so who do you identify? And you were just describing LPNs or RNs taking on this role. And as I think about it, the kind of people I've looked for are people who already have some skills in care management for other chronic conditions. So maybe they're care managing for diabetes or heart disease. They're good communicators. And some of the specialized behavioral health skills, in my view, are relatively easy to acquire, like learning how to interpret a PHQ-9, not rocket science. But some of them are a bit tougher, like learning to do motivational interviewing, learning how to help patients with behavioral activation. And so I think those do require more longitudinal training, ideally other care managers that they can talk to. The beauty of it is motivational interviewing isn't just for mental health. We do it for all kinds of behavior change. And so it's a skill that translates well to the role of being a care manager, no matter what condition it is that you're supporting and being the care manager for.
It's apparent that training can build comfortability and confidence. This really helps with asking patients those difficult and sometimes very sensitive questions related to behavioral health conditions. Another skill set is the importance of motivational interviewing, which is a powerful tool to support behavior change. There's one additional element in behavioral health care we need to include, and that is how the care manager and primary care provider utilize psychiatric consultation for decision support.
I wanted to loop in the role of the prescribing mental health professional here, because although care management can meet the needs for many patients with behavioral health needs in primary care, it doesn't meet the needs for everyone. And so the prescribing mental health professional does a number of things. They answer the questions of the primary care physician and the care manager. They can prescribe advice on psychotropics, particularly on drug-drug interactions and drug-disease interactions, what drug might be the best. They can help with diagnosis about additional questions that need to be asked. And they can also facilitate referral to longer-term mental health specialty care. So the prescribing mental health professional is a really valuable part of the team, and I think helps the care manager and primary care clinician have the confidence that they can do this because they have a content expert there that they can rely on.
John, I do want to go back to what you said around the med prescriber. What I've seen is that PCPs oftentimes feel more confident in treating patients that have underlying psychiatric conditions. So it really expands the skills of primary care providers and allows them to treat patients in a place that they feel more comfortable.
I think that's exactly right. I've probably participated in 200 to 300 care management meetings for our panel of patients with mental health conditions. And just sitting with a psychiatrist and the care manager and discussing patients over time and discussing the panel of patients, it has increased my confidence in my ability to manage mental health problems.
We owe a big thank you to Dr. Williams and Wendy. We've heard about the benefits of integrating a behavioral health care manager and a consulting mental health professional into the care team. We've learned about some of the essential training and skills that are crucial to this role. And we've heard real examples of how to integrate these two professionals and their services into clinical workflows. Please make sure to listen to the other two podcasts that discuss insights for two models of behavioral health integration: Identifying Patients for Behavioral Health Services and the Primary Care Behaviorist Model. And thanks to those of you listening to this episode. We really encourage you to share these CPC Plus Tactics to Go strategies with everyone in your practice. Thank you and good day.